projection. Sorry about that if you didn't hear. But I just wanted to share, our work around innovation really started with our 2012 strategic plan, where we really identified the need to create a culture for innovation. And I'm excited to say, 10 years later, we are well in that path of culture, and now we're going to that next phase of innovation, and a well-developed system within our hospital that continues even with our plan that we just finalized actually in 2020, that has our mission, vision, really focused, including innovation, as well as a key strategy within our strategic plan under our value strategic goal to really invest in innovation. And so that's when I talk about going to the next level and really building out our portfolio of innovation, whether it be internal innovation that we're investing in or external innovation that we're investing in. And so we're really excited about that. Next slide. One of the things that, hopefully all of you are familiar with Children's Mercy, but we are a nonprofit. We are a freestanding independent children's hospital, and we are very proud of that. We're not part of a system, and we're one of only a few children's hospitals in this country. There's around 30 independent freestanding children's hospitals, and we truly are one of the leaders in pediatric healthcare, not just for our region, but even nationally, and nationally recognized in 10 specialties within the U.S. News and World Report. We are the regional provider for kids, and you see that with all of our locations that we have around the metro, 2 hospital system, as well as ambulatory centers, east, west, north, our Kansas facility, as well as regional sites that we have in St. Joe, in Wichita, Joplin, and other areas throughout both Missouri and Kansas. We do have a focus. Hopefully you all see the beautiful research institute that we have up there on the hill that was developed and opened really during COVID. Unfortunately, we weren't able to have a huge celebration, invite all the community there, but we do have focus areas. And one that I'm really excited, just work that we'll be announcing fairly soon, this time in August timeframe, really is our Genomics Focus and our Genomics Answers for Kids, and the work that we're doing in genomics. We've been a leader in this space. We were the first freestanding children's hospital to invest in genomic medicine. And so you will see the result of that very soon as we announce some great things that we have accomplished with our Genomic Answers for Kids, as well as other focus areas that we have in precision therapeutics. We are seen as the leader when it comes to therapeutic medicine for kiddos. Then, of course, I mentioned the invest in innovation. So enough about me. Let's talk about innovation at Children's Mercy and really how we practice innovation day to day. And really, it's a collaborative process that is led by all the folks. And I'll turn it over to Kristen Nelson, who is our Director of Innovation Development.
Thank you, Dawn. Thank you so much for having us. And as Dawn said, we had this big plan about 10 years ago, and we've really focused on a culture of innovation within our institution. And as you can imagine, with the compassion and the type of people we have at Children's Mercy, they are naturally empathetic with what their situations are and what's happening with the patients and families. And when they are that way, then they're always looking for better ways of doing things. And that's where innovation sparks from. And so we had a pretty easy time to get ideas generated and that type of thing. But having a system and a process to get those ideas actually and bring them to life is what we've been developing over the last, and I've been there about 7 years. And so with that, we, feel like we have really established a good culture. We just had what we call our Spark Bash, which is a maker fair. And we had usually between 15 and 20 employees a year submit ideas, and we highlight them at our maker fair. This year we were back in person, which was very exciting. But that again just creates this culture and this opportunity for any employee. We had respiratory therapists, we had an IS person, we had nurses and doctors and all types of specialty, focus areas that submitted ideas. And so that really does generate this culture of innovation. So we feel like we've done that pretty well over the years. But again, trying to figure out how do you get something from concept to market? And that's really what we're going to share with you today. Is we're going to give you just a kind of a thin line of how end to end we've gone about doing that and creating the infrastructure that allows us to bring ideas to fruition. And so we've created an innovator roadmap, and this is something we share with our innovators and just help them understand that, you know what, first we're going to go through need validation, and we'll share what that looks like. And then we go through solution validation, and then we do market validation. So for any of you in the innovation space, this is not new news, but we'll just share how we've been able to put together the kind of the infrastructure and the ecosystem to do that at Children's Mercy. And so it all starts with needs. And that's where we begin. It continues with needs as we go through solution validation. You validate that the solution truly is meeting the needs that you've uncovered. And it ends with needs. We've got to meet the needs once it hits the market. And so with that, we use a human-centered design approach, which I'm sure is all familiar with anyone in this space. And as I mentioned, our frontline staff and really everyone at Children's Mercy naturally does this. They're naturally empathetic to what they're looking at and dealing with on a daily basis. And we really come in and help them to clearly articulate what we want to go solve for, help them to ideate the right solution, and then prototype and test. And this is kind of the front end of innovation that we will start sharing with you now. So I love this picture. And I want all of you to look at this picture because this is something a nurse or whoever it would be in a patient room would see. And when it comes to innovation, it's all about meeting needs and defining either, what potentially are articulated needs or even unarticulated needs. So obviously this baby can't talk, right? But if any of you in the audience were to say, what's going to happen with this central line that was placed on this baby? What are some needs that just could be observed? What could happen? Is the baby just going to lay there beautifully, sucking her thumb the whole time? Right? I mean, nobody has to say anything, and you're already going to know that there has to be an innovation here, right? The baby's going to pull on the lines. They're going to come out. It's going to hurt. The baby has tape across its chest, The baby's probably saying, if he could talk, what's this tape? It hurts. I don't, get it off of me, just, and then also they're hanging down by the diaper, right? What's the opportunity for some kind of infection or something taking place, right? So there's all kinds of things a baby is wishing for and wanting and needing. And I'm sure the mom is definitely thinking about it, even if nothing's articulated in the room. There are needs that we as, in our business are observing every day. And I'm sure in your businesses as well, as you're looking at what opportunities you have, what your customers need, what's not being said, getting out and observing and empathizing in this situation is what we do every day. And this is where ideas come to life. And so this will eventually result in solving for those needs, which could become a product, so some kind of medical device, a tool, maybe some new content. Maybe it's more about education. So we need education content for the family. Or it's some new technology. But it could also be a new service we want to offer, a new experience. Maybe we're creating a whole new business model or new business line. But it also could be a research discovery. Maybe there's something that our research institute's very much involved in new discoveries to solve for big needs that we have in pediatrics. And so with that, as we think about those needs and as our clinicians come to us and they say, we've got these needs, we want to do something better for our patients and families, we need to validate that. And so is there truly a need there, and is there a problem we really should go solve? And this is where we are so fortunate to have Dr. Sarah Bouquet, who has her PhD in human factors. And so for anyone that isn't familiar with this field, it's just so needed in the realm of innovation. And so I'll let her talk more about that and share kind of what we do to continue to validate the needs are there.
Thanks, Krista. So show of hands, how many people here have heard of human factors before? Okay, good. This is like more than usual when I ask that question. So I work closely with Innovation Center a lot, especially in this sort of product development piece, but I also work in patient safety and alongside the QI team as well. So when I sort of put my human factors lens on, it is looking at people a lot of times bring solutions to a table, assuming they know the needs, right? So human factors kind of pops in and says, are the solutions that we're creating the right ones, and who are we asking that question to? So in my line of work, do a lot of observations, do a lot of question asking, going to the front line and seeing to make sure that those needs are there. Sometimes we assume we know, right? And so that's kind of this work as imagined versus work as done, right? Work as imagined for me, as I don't have a medical background, is I don't know how medicine really works, so I have to go out and watch, right? Work as prescribed is when your leader says, oh yeah, they do this, and this is how it happens, right? Not really reality. Work as disclosed, right? Your policies, your audits, your reports, probably still not actually work. And then really work as done. So going out and seeing how it happens, looking at those processes, not only looking at it from the lens of providers, but also from the lens of patients and families. So a perfect example that Brandon's going to talk about here in a minute is we created a tool that we thought would really help rural providers who aren't used to seeing pediatrics. And we assumed they needed like up-to-date, easy access information, like right in the moment, as they're treating a kid. Well, then we went out there to Dodge City, which is a long drive out there. And they were like, actually, Sarah, we're going to be riding in that ambulance for like an hour and a half. So we have a long time to look at this app and prepare ourselves. And so we thought, oh, okay, but you might not know like how old the kid is or how big they are, and you have to wait till you get there. And they're like, no, yeah, we know everybody within this whole district because it's very small, and they were at the birthday party last week. So that was something, right, from our end, we thought we were meeting their needs, and from the general perspective we were, but we weren't considering the context and that work is done that we initially thought.
So I'm playing our director of tech transfer now. She was not able to come tonight, but she would have got up and really shared with you that at this point, a lot of times, especially with research discovery, we may not go into the next phase, which is solution development. We may, at this point, identify the need, understand that we have something that is worth solving for. We have a problem we need to solve for, and we actually have some type of invention that we've made it this far through all this needs analysis and the research work that's been happening. And so from a intellectual property perspective and really understanding if we have something unique to take to the market, Marcia would come in and really assess what is the size of the market. And as you can imagine, in pediatrics, our market sizes are always a lot smaller. And which is, reflective of the amount of investment, either from the government or other grant opportunities, that pediatrics gets about 5% of the totals. That's why we're doing this, really, because we have to fend for ourselves, because there's not the big adult, either, pharma or medical device, developers that are focusing on peds. And so with that, we assess the size of the market, and Sally's going to talk a little bit later about how do we measure that, because it's not always ROI. A lot of times it's ROM, which is return on mission, is why we do a lot of things that we do. And so she'll, do a lot of assessment of the market, look at alternatives in the market, of course, to see if we have a differentiated product or position or discovery or whatever that looks like, and then really look at the patent landscape. Because at this point, if we have something worth patenting, we'll patent it. We'll be ready to potentially license that out, which is really what she's assessing. Is it going to be worth our investment to take it through the rest of solution development, maybe even trials or FDA regulatory processes and such? And Jenny will talk a little bit about that. Or do we just want to license it out right now? And do we have value in that patent that we could license out? So we're doing that assessment really early on, and then we continue that assessment throughout the life cycle. But in the case we do take something through development, this is where we now go into solution validation. So we validated the needs are there. We validated we have a solution, a problem we want to go solve for. And so now we're going to go into solution development. And so really, it's all about iterating and testing and learning and all of that. And we always start with some low-cost prototyping to really do some early stage usability testing, which Sarah will get up and talk about that here in a minute as well. We definitely utilize for products. We'll do 3D printing. We have a great relationship with some academic universities like Kansas State, who does prototyping, 3D renderings and prototyping and printing, 3D printing for us, and that we actually can take those into some initial studies. And so with that, we also work with technology companies, and we even worked with a seamstress. So we're really building out our ecosystem across. We like to do local as much as we can, and to create those capabilities that we need to deliver the solutions we're trying to develop. And so I'll turn it over to Dr. Kennedy to just share what it's like to be an innovator, a physician, a subject matter expert, and an informatist, and all kinds of other things that he does to help bring in some innovations to life here.
Wow, you guys all need to lower your expectations a little bit. So I'm Brandon Kennedy. I'm a pediatric hospitalist here, and I've been practicing for probably about 25, almost 30 years. I've been in the ambulatory space as a private pediatrician, and then I came back to academic medicine here at Children's Mercy. And then I've always been a little bit of a computer geek and kind of into the technology thing. So about 10 years ago, I started down the realm of health information technology. And so, and believe it or not, because of need, there is a clinical board subspecialty in clinical informatics from the Board of Preventative Medicine. So it's actually like a pulmonologist or an endocrinologist. There is a clinical subspecialty in informatics and technology. And that's because we have to do it this way now. So I think the best way to kind of present this in the form, in talking about, innovating solutions, physicians live in a cognitively overloaded world. Right now, they estimate that the fund of general medical knowledge, the global medical knowledge available to physicians, doubles about every 3 years. So if you think about that as a medical student, you start medicine, and before you even finish, the amount of available knowledge is doubled. And so you're supposed to be learning this. It's also estimated that we face about 600 facts per decision, and human cognitive capacity is about 6 to 10. And then the final piece of that is, if we look at existing research, there's 33 million citations in PubMed, which is the medical research database. 33 million, with 1 million new publications annually. So we better get reading if we're going to catch up on all this information, right? And so the point is it's about how do you translate medicine, and you translate that information and that knowledge into practice. And it's been a struggle in medicine for years, for 50 years. That's been a struggle in medicine because it ends up taking time before it actually translates into practice. So the notion here is that what we wanted to do is we wanted to be able to translate some of that research and some of that new practice and guidelines and recommendations about how to treat kids, and take it from complicated forms in which it's initially presented, which is a branching algorithm with a lot of yes, no questions, a lot of information, and break it down to a much more quickly, easily digestible form, decrease that cognitive load, and give physicians that information as quickly and easily as possible so they can use it and right in the workflow of their care. So they can whip that out and go, oh my gosh. And so frontline providers, like a community ER physician, they don't see kids. They see kids maybe 7% of the time, certainly less than 10% of the time. It's mostly adults. And so sometimes, and you'll hear them say, oh my God, there's a 2-month in rolling in the door, and they're like, it's freak out time because they just don't like to see those little babies. They kind of be intimidated by those patients, but they're very capable of taking care of them. What we see in our hospital sometimes is they get referred in, and maybe they don't do quite all the right things. They do the main right things, but sometimes there's some other things they could have done. And it's how can we provide them with that knowledge in an easy way? And so that's actually kind of what came about with Peds Guide. And the notion was to kind of build that information out, and so that frontline providers can have access to this information in real time quickly. So if they have a burn patient, or if they have an asthma attack in a small child, or if they have a 2-month-old with a fever, they can look, assess that patient, get to the data points they need to obtain, help them with assessment, and help them take the right actions at the front line of care, which has a profound effect on the downstream care of that patient as she comes into a tertiary pediatric center. And so we've already heard some stories that have been impactful from people, even in different parts of the country, about how, oh my gosh, this helped me make some decisions up front that really impacted the care of this child. So, so that's the goal of this, and it we have about 60,000 users now. And we've gotten responses and some collaborations on the national level. So, so this is, I think, has a lot of ongoing potential for expansion and development. I need to emphasize, this is not my sole baby here. This takes a massive undertaking of a big group of people. We had to come up with a strong sustainability model that includes a medical librarian, evidence-based practice physicians and expertise, clinical champions to help us with the with putting these together, regression testing models, finance models, legal. I mean, it's a huge team of people, and Sarah, she's vital to this whole thing too. And because it's all about design and how we do this and how we put it together. And so I kind of heard the cats, so to speak. But I love this because it can have such an impact on how we take care of kids.
Thank you, Dr. Kennedy. So yeah, this is just a great example of how we need the clinical expertise, right? Sarah, we don't have medical backgrounds. And so obviously what we go into solution development with is a team. And just as Dr. Kennedy described, it takes all of us to make these things come to life. And so we have all those roles that are willing to play that role. And then I think just really even just emphasizing how as a pediatric hospital, we know what it's going to take to integrate things into clinical flow. And I think that's when one thing, if you're kind of maybe you're trying to innovate in the medical space, and you're not in the medical space, but you're trying to create a solution to do that, you really need to understand, how will this integrate? How does this integrate into hospital processes, policies, clinical flow? How do patients and families are going to use my solution? So obviously we have an advantage because we live it every day. And so we can see it and we can test it and we can figure that out. But for those that aren't, that's going to be a critical aspect to your success. So, once we get a solution, developed, in this case, this was a software solution. And so we had software vendors and developers help us with this. But as we iterated it, Sarah's going to talk next about how did we validate that we were creating the right thing.
Yes, so we do a lot of usability testing for products, software, hardware. We even do it in the hospital just operationally with form design and workflows. But really when we talk about usability, we're not just talking about the functionality of it, right? We're talking about, is it providing appropriate feedback? Is there error correction? Is it learnable, memorable, so that, if they don't access Peds Guide for another 10 months until the next time they see a kiddo, do they know right away how to use it? Like, oh, I remember this is the flow it's going to walk me through. But especially when it comes to healthcare, right, you're also looking at things like Brandon kind of was alluding to, but mental workload, trust, right? If you build this app and it does not look great. We've all been to a website where you're like, this is sketchy, does not look appropriate. So that's also important pieces of design that we kind of look for and measure for. And then I would say for most of our usability studies and sort of the Norman Nielsen standard is with only 5 users, you can catch about 70% of usability errors. And so we try to iterate after 5. We've done bigger studies. So we did a study with Peds Guide, and we showed with 16 residents versus 16 attendings, just a phenomenal difference in workload reduction compared to, using just a book, right? So if you click again, I'll kind of just walk through sort of what it looks like when we do the usability test. So depending on what we're building or looking at, so doing the tasks, right? Going back to that needs assessment. Are we measuring the right thing? Do we know what the answer should be? And are they getting there with our app or solution? And then we recruit our participants. This is really important for diversity and inclusion, right? We can't just take the Children's Mercy people, right? Those are our PEDS people. So are we getting residents from other institutions? Are we going out to Garden City and recruiting there? And then setting up the environment. Most of the time it's simulated. These usability studies are, especially with prototypes where we're early in design. We do try to do some in situ usability testing, which is a little bit more difficult and tends to be further along in product development. Conduct the test, and then we do analyze the data. So basic statistics. We're not doing anything complex at this level, mostly t-tests and ANOVAs and correlations. And then reporting results. So in grad school, I had a professor tell me that human factors is telling people their baby is ugly. So these prototypes, people feel a certain way about them and how wonderful and all the needs they're going to provide a solution for. So part of communicating those results is saying, yes, we understand. However, if your users are failing tasks, not getting the right answer, then we need to iterate and test again. That's hard to hear, especially, nobody likes to hear that, whether they're an engineer, a software developer, a physician. So that's part of sort of the process here that we work really well as a team. I know we tag team some of these conversations and really polish them before their delivery. But that's sort of our usability testing. I will say we've had experiences, not at Children's Mercy that I've seen so far, fingers crossed, but I did a project for a company that rhymes with Motorola. And we did a usability test on a product, and they did not like our design recommendations. And one of our participants literally said, when we asked them, how likely are you to buy this product? And they said, not only not am I going to buy this product, but I would pay them to take it back from me. So, right, how do you give that back to Motorola? In a way that provides recommendations, but also says like, hey, you need to hit the drawing board again. So they ended up not listening. And the last time I looked on Amazon, it tanked. So just driving home again, the importance for this, but also its application beyond healthcare.
I've only cried a couple times.
Thanks, Sarah. Yeah. So when I first started at Children's Mercy, when I realized what Sarah's role was and what she brought to the table, I was like, we have to partner. And so we right away got together and worked on how we could, work together to improve innovation solutions. So that's kind of, we do this both for software, we do this for products. And so Jenny's going to talk a little bit about when we have a physical product, what are, or even a non-physical, but in most cases a physical product, how do we truly validate that within our studies and that type of thing?
Hi, everyone. I'm Jenny Marshall. I'm the Director of Feasibility and Strategic for the Department of Strategic Planning. Sorry about that. I've been with Children's Mercy for over 20 years and with the Heart Center for most of that time, and have since moved to strategic planning as of this past January. What I was doing with the Heart Center is I was their director of research, and that was after working in their OR and doing clinical research and other roles for them. So I am a nurse, I am a respiratory therapist, and what I do is I really try to work with whomever is developing a product. And like Krista was saying, that could be a physical device. It could be some kind of a program or something like that. For the most part, though, I do a lot of device work. And so I help people as they're testing their device, and I help to kind of walk them through the process. So not only within the hospital, so we have research studies and we have the healthcare industry regulations. So like within a hospital, you have your institutional research board, and you have to abide by all of their regulations when you're working with human subjects. Then you also have, if you're doing animal studies, you have an IACUC, and if you have biomedical studies, then you're working with an IBC. So there's many different groups that you have to work with. And so I'm kind of the guide as they go through all these different processes to help tell them, okay, now we need to sign here, and now we need to put it in here. And yes, I know it sounds very bureaucratic, but we have to do it anyway. And so I help to guide them through these different processes. Well, I also help with some of the FDA aspects as well. We do partner with other outside consultation groups that work very closely with the FDA. But I also help to prepare our people for meeting with these groups and to get them to where we are even at a place where we even think we have something to present to one of these groups. So, as we were saying with the usability studies, well, then we're going to go, okay, yes, we have a product that, is working, we have good results, but how are we going to be able to say, okay, is it going to work in more than the 10 kids we tried it in? Is it going to work in another clinic? And so then we get into the clinic workflows, and we get into trying to figure out how this would actually work in the day-to-day operations of the hospital. So I help them through those different aspects. And then I do a lot of solution iterations. So I had to put up my Pdsa Cycle because just because we've gone through usability, we've gone through feasibility, that doesn't mean development has stopped. Even after we've gone to the FDA, development doesn't stop. And the FDA knows that development will continue. And so we have to figure out what aspects of this need to be revised and what aspects do we like. And even if you like everything, things can still be improved upon. And it's sometimes hard for clinicians to hear that because they feel like, I've developed this, we're good to go. And yes, it is good right now. But in order to stay innovative, you have to think beyond that. You have to think long-term. What are some of the long-term aspirations of the product that you want to develop? And so I try to kind of guide people through that. So, as we go through different presentations, I'll talk more about all of that.
So, a lot of times as a hospital, you'd wonder, well, why are we doing all this? Why wouldn't we just, license out right away? Or, so I think the key is that we want to make sure that we have something that is going to be right for pediatrics. And also the fact that we're trying to really, frankly, get a bigger piece of the pie, right? When we license out, we're getting, very small percentages of that from a royalty perspective. And we have all these capabilities ready and expertise ready to go. And so we can de-risk. We can go through this process and de-risk solutions to a certain point to then when we are ready to go to market, we have a bigger seat at the table. And we have expertise and we're able to approach major manufacturers with all this data and all this information to really, frankly, have a bigger, a bigger piece of the pie. And again, when we get a bigger piece of the pie as a nonprofit institution, that goes right back into the next innovation and right back into more research. And so, it's all mission based, but again, we're able to really give our opportunities to our employees. Our IP policy gives a percentage of the revenues that come in back to that employee. It goes right in their pocket. I know I've been in the corporate world and innovated a lot of things and not one penny came back to me, right? But our innovators do get a piece of that. And so then the rest, another portion goes back into again, more research and more innovation. And so when we think about going to market, Sally is going to share kind of what that looks like and kind of how we measure that.
Thank you, Krista. If nothing else, hopefully you've understood that innovation is a team sport. And what's really unique about Children's Mercy is we have a really diverse set of skill sets, from clinicians to frontline staff to all of our research and regulatory team, to where the combination of what we have is really unique. And so when we go to take something to market, we really look at what's going on specifically with the need to define what that strategic path is. And so for as many innovations that we can have multiple go-to-market strategies. And what's unique about Children's Mercy as well, which is a little bit different than corporate companies that Kristen and I have worked for, is it's not strictly ROI in the traditional ROI sense. Because we are a nonprofit, we start first and foremost is, will this move our mission forward? Will this advance what we've said we want to do? If it doesn't, and there's a patent there, we can quickly take this out, license it, and keep moving on with our internal resources. But that's really at the heart of what we start with. The second pieces are a little bit, all of these are related, but reputation and sustainability have a unique relationship. Reputation is one way of saying your brand. Your brand can be relative to our local market. It can be our national market, but it also is within academic peer groups to be able to get access additional funds. So if your reputation is really high and you're applying for an NIH grant, you're going to likely get that grant if you have that reputation and foundation of publications, of being able to present at conferences, and be able to show the impact of what you're doing within your field. And that has its own currency, so to speak, that has more of a long-term monetary benefit, but it's something that's really important for Children's Mercy to take into account when we're deciding if an innovation should move forward. And of course, we have the obvious sustainability. Even as a nonprofit, we have to make sure that we're sustaining it so we can do the next innovation. And so sustainability can take the form of grant funding, it can take the form of philanthropic funding, and then as Krista said, we really want to be looking more at how is Children's Mercy benefiting financially from a particular innovation. So revenue directly from an innovation is also part of that equation. And so what you've hopefully heard today is also the unique components of when we look to develop an innovation. It's really rooted in deep empathy, deep need, and an expertise around how is this need going to actually be applied in the market. And what we're finding is we are our own customers. And so when we look at understanding, when we have a need, we go out and look at other pediatric institutions and say, do you have the same need? By being able to validate that that market exists is a huge component of us moving into the future phases. But then we go into production, marketing, scaling, development. Those really take the traditional buy, build, partner models. How many of those are things that we have skill sets in-house, and how many of them are ones that we need to partner? So for the app development that we just shared with you to develop Peds Guide, we have chosen not to have those app developers staffed at Children's Mercy, but we work with an outside app developer to do those pieces. However, the full go-to-market and scale is tied to Children's Mercy because the ongoing maintenance of those algorithms and decision support is something that's tied to our core competency. Other medical devices that we would be putting out there, because we're not a manufacturer, because we're not a distributor of medical products, those are ones that we tend not to take all the way through the market. However, we have a really exciting innovation that we're really proud of at this point. Is we've noticed that a lot of other pediatric institutions have the same barriers of taking products all the way to market, mainly because our market is fragmented. The cost to get into other institutions is really high in order to change protocols that are in place. And the clinical validation of saying something works is also very expensive, finding those populations that are really unique. We are really excited to be working with the International Society of Pediatric Innovation for Children's Mercy to be launching a Pediatric Marketplace. And that marketplace allows us almost like an Etsy for other institutions who would be both purchasers and sellers within the same market, really to advance pediatric innovation more quickly and to take on a lot of the go-to-market barriers that all of us at the institutions have had. So this is kind of a pretty ambidextrous chart. It really relies on the team sport of all the expertise that you've heard just the tip of the iceberg of. But if you have any other questions on it, we'll be happy to answer those as we go.
Yes, so thank you for listening to our presentation today.